Welcome back. Today we're going to be talking about managing crises in jail. We'll go over what constitutes a crisis, typical responses and solutions, and problems you might run into. Before we get into it, I want to put a disclaimer at the front of this one. I'm going to be talking about jails in general and what constitutes a crisis relative to the other things that jails deal with. If you have a problem and I say something like, this or that diagnosis is not a crisis, that doesn't mean that I am lacking in empathy or trying to invalidate your experience. I'm just trying to explain how jails prioritize limited resources. So, with that out of the way, let's get started. First, we need to define mental health crisis. We can think about the problems inmates experience in jail as existing on a spectrum. I sort of mentally break down inmate problems into 3 tiers. We'll talk about the lowest tier first, which are what I call situational stressors. These are things like anxiety, depression, insomnia that didn't exist prior to incarceration. In actuality, these are normal side effects of incarceration. A person who's incarcerated experiences a sudden and profound loss of freedom and autonomy. They lose access to friends and family, they lose access to their job, and by extension, their means of paying for their home or vehicle if they have one. They lose access to all the things they've taken for granted, like going to sleep in their own bed or getting to choose what to eat for breakfast. And while this is happening, the inmate doesn't know how their legal case will play out. Will they take a plea? How much time will they get? Will this impact their relationships or their ability to get a job? This is only a small number of the natural consequences of the jail environment. My point here is that feeling depressed, feeling anxious, feeling angry, having trouble sleeping, these are all normal and predictable experiences in jails. None of these emotions are, in and of themselves, a crisis. In my jail, if you're having trouble adjusting to the jail environment and want to talk to a counselor, I will send one to see you. But what I won't do is pull you out of general population to put you in the mental health unit. And I won't schedule you an appointment with a prescriber so that they can give you medication to stop you from experiencing a normal emotional response to your situation. On this same tier of the spectrum, you have inmates who had a pre-existing mental health issue outside of the jail. If an inmate comes into the jail with a pre-existing mental health diagnosis, I'll usually have one of our therapists meet with them for an evaluation to see how severe the symptoms are currently, and we'll see about restarting any medications the inmate was taking on the outside. If you have ADHD and take a prescription stimulant, most jails are not going to give you this medication because stimulants have a high trade value in jail. You might be able to get a non-stimulant medication instead, but generally speaking, this is a low priority issue in jails. Also, if you take a daily benzodiazepine or hypnotic for anxiety or sleep, you're probably not going to get that in jail either for the same reason. They're potentially dangerous and they have too much trade value. Jails are more concerned about pre-existing diagnoses like major depressive disorder, PTSD, bipolar disorder, or any of the psychotic disorders like schizophrenia or schizoaffective disorder. As long as the inmates are stable and willing to take their medication, all of them will be housed in general population regardless of their diagnosis. One last thing worth mentioning while we're talking about low-level issues. It's fairly common for mental health to get a call from officers saying that an inmate is flipping out or losing it, or some other generic term for a person in a crisis. We show up and sit with the inmate who's sweating, feeling lightheaded and dizzy, complaining of racing thoughts and inability to sit still, and often thinks they're having a heart attack or a brain aneurysm. In reality, what they're experiencing is a panic attack. And panic attacks are quite unpleasant, but they aren't very dangerous. Ironically, people in a panic attack often worry about passing out, which is basically impossible to do during a panic attack because you have too much adrenaline in your bloodstream for that. I kind of like talking to people about panic attacks because they're often understood and very treatable. But the important thing to note here is that panic attacks are often triggered by stressful experiences. And what is jail? A stressful experience. One thing you don't want to do for panic attacks is to medicate them because you'll end up making the problem worse. So anyway, if an inmate has a panic attack, a counselor should go and see them and help them to calm down. But a panic attack is not a crisis, and it's not going to get you moved out of general population. So of all the things we've talked about so far, none of them constitute a crisis in a jail. Now let's talk about the second level of the spectrum, things that might be a crisis and things that aren't a crisis per se, but still require some sort of response. Let's start with the most common one. Inmates telling officers that they're suicidal. That'll get your attention, right? If you remember, the first 2 rules of jail mental health are that no one dies in the jail, so we absolutely cannot have inmates killing themselves. The inmates know that suicides in jails bring all sorts of negative attention and potential liability to the jail. Armed with this knowledge, they also know that the 100% guaranteed way to get an officer to stop what they're doing and pay attention to you is to say you're suicidal. As a result, jails are constantly dealing with inmates claiming to be suicidal. In my experience, the vast majority of the time when an inmate claims to be suicidal, they are not in fact suicidal. They're saying they're suicidal for some sort of secondary gain. Maybe they don't like their roommate, maybe their section is on lockdown, maybe the TV went out and they want to get moved to mental health so that they can watch the football game. There are 100 different reasons that an inmate might pretend to be suicidal. In the clinical world, when a person pretends to have problems they don't actually have, we call this malingering. Malingering is a robust topic, so we won't go too in-depth today, but know that it's extremely common in jails. And one of the main jobs of your mental health team is to tease out the malingering from the genuine mental illness. If the counselor deems that the risk of suicide is anything other than low, they should move the inmate to suicide watch. If the counselor determines that the inmate is malingering, then they'll try to talk through the situation with the inmate to get to the root of the actual problem. Sometimes these issues can be resolved by moving the inmate to another section in general population, moving them to protective custody, or looking up their court date for them. If the counselor can't resolve the issue and the inmate continues to pretend to be suicidal, then the counselor will almost always put them on suicide watch. But wait, I can hear some of you saying. If you're the mental health expert and you just determined that the inmate is malingering, why are you still putting them on suicide watch? I'm so glad you asked. You have to understand how a jail works for this to make sense. Let's say you realize the inmate is malingering. You tell the officer, go ahead and put him back in his section because he's faking. What do you think happens next? The inmate is already misbehaving to get his needs met. Ignoring him again is only going to encourage him to step up the misbehavior. The next thing you know, he's popped a sprinkler, flooded his cell, started a fire, assaulted someone, or some other sort of destructive or dangerous nonsense. Now, even if the inmate doesn't do any of these things, he could always just push the intercom button again in 20 minutes and say he's feeling suicidal again. If you're mental health, you can either yo-yo yourself back there to talk to the inmate again so he can keep trying to convince you to put him on suicide watch, or you can leave him there. The problem with leaving him there is that you're now putting your officer in an awkward situation. Even if your officers have mental health training, you shouldn't be expecting them to know when an inmate is genuinely suicidal or just playing games. And if anything happens, your mental health department is going to look really stupid because they just documented that the inmate was malingering. One of the things that still scares me the most working in a jail is the possibility of an inmate accidentally killing himself while pretending to kill himself. Inmates who don't get put on suicide watch when they're malingering will often wrap something around their neck or make a ligature to prove how serious they are. Some of them even lean into their ligature so that they start to choke. Now, let's say one of them accidentally takes it a little too far and can't get their sheet untied or get back on their feet and strangles himself to death. When CSI comes to investigate the scene of the death, they're going to have no idea that the inmate accidentally killed himself. It's going to look like a genuine and intentional suicide, and you know what that means. Fingers are going to get pointed at the mental health worker on the assumption that they must not have done a very good suicide risk assessment. For whatever reason, many people are operating under the assumption that therapists can somehow predict suicides. They can't. That's not how risk assessment works. And in this case, you're going to have a bunch of witnesses who will say they just heard the inmate say he was suicidal an hour before he died. Putting malingering inmates on suicide watch isn't done for clinical reasons. It's done for behavior and liability management reasons. Okay, so that was just malingering suicide. I know that was a lot, but about 50% of calls for mental health are for someone pretending to be suicidal, so it's important to understand the dynamics at play. Let's move on. What if the inmate is having hallucinations? This is potentially a crisis, but usually it isn't. Most of the time, people who have genuine hallucinations don't raise their hand to alert someone that they're having hallucinations, so an inmate telling an officer he's hallucinating already raises a red flag for possible malingering. However, that isn't always the case. People can have genuine hallucinations and have an awareness that they are hallucinating. In these situations, mental health has to evaluate the patient to determine if the hallucinations are severe enough to warrant moving them to the mental health section. The general rule is, if the hallucinations are not significantly interfering with the inmate's ability to function, and if the inmate is willing to stay in their section, then you don't move them. You might set them up with an appointment for one of your mental health prescribers, but it really depends on the context. For example, an inmate tells you he hears the voices of deceased relatives. Okay, so what are these voices saying? If the voices are saying things like, "You've got this," "Make me proud," then this is not a crisis. However, if the inmate says that the voices are telling him to kill his cellmate or that the food is poisoned, that is a crisis. This is of course assuming that the inmate is not malingering. Now, we have methods of detecting who is malingering, but I won't share them here because I don't want to teach anyone how to malinger. But assuming that the inmate is having these auditory command hallucinations and that the commands are violent or dangerous, then you want to move this inmate out of general population and into the mental health section for treatment. The next type of crisis call that mental health has to manage are when inmates get kited out of their section for bizarre behavior. What does it mean to say an inmate is kited? A kite is a note usually written anonymously and passed to corrections officers. The note will usually say something like, "Get Jim out of this section or we're going to have a problem," or "Can you move Fred because he's doing XYZ and I think someone might hurt him." Kites are usually an officer problem, but they sometimes involve mental health when the kite has information claiming that the inmate in question needs to leave the section because he is bizarre or mentally ill. When this happens, mental health gets called and then has to determine if the inmate is actually having bizarre behavior or if there might be some alternative reason people are trying to kite him out. The counselor then liaises with the officer in the section to figure out if the inmate needs to go to mental health, protective custody, or just a different section in general population. The last category of "this isn't a crisis per se" issues that come up is sort of a grab bag of uncommon scenarios. For example, you can have an inmate who has an intellectual disability or autism. These aren't mental health crises per se, but you probably don't want to put them in general population lest they be taken advantage of. Inmates who are blind or deaf may need to be housed in the mental health unit depending on how your jail is set up. And finally, your mental health team may get called to help with housing for transgender inmates. This is really an issue for the classification team, which should be knowledgeable about PREA guidelines, but mental health may get called anyway to give a recommendation based on their knowledge of the inmate and any past interactions with the mental health team. Okay, let's move on to issues that are the top tier of the crisis spectrum. Those that require movement to the mental health section, clinical restraint, involuntary medication, or hospitalization. Each of these interventions in one way or another require us to assess the inmate to determine if he is either suicidal, likely to be violent toward other people, or is gravely disabled by his mental illness. Here are some examples. The patient made a suicide attempt or is found cutting himself in his section. The patient says he hears voices telling him to kill other inmates. The patient won't eat because he says the food is poisoned. The patient won't come out of his cell because he's afraid someone will kill him. The patient is unable to maintain his hygiene, smears feces around his cell, or is unable to have a coherent conversation with jail staff. So what do we do in these circumstances? The first thing you do is move the patient to the mental health unit if you have one. If you don't have one, then they need to go to the medical unit. If you don't have a medical unit, you really should have one. Unless your jail is super tiny and only holds like 10 inmates, in which case you're going to have to take people to a hospital whenever there's a problem. Anyway, once they're in the mental health unit, you want the suicidal inmates on suicide watch, which was discussed extensively in a previous video. The same goes for the homicidal inmates, with the caveat that you don't want to put anyone in their cell with them. The inmates who are disabled or psychotic but not at imminent risk of harm should also come to your mental health or medical section and can have a roommate as long as it makes sense to do so. Now, the most acute crisis we have to deal with from a mental health standpoint are inmates who are actively trying to harm themselves or others and those who are gravely disabled. In these situations, we might need to apply one or more of the most invasive mental health interventions available to us, which are involuntary psychotropic medications, clinical restraints, and seclusion. I know we're going a bit long at this point, but this is really the meat and potatoes of acute mental health care in jails. So first, let's talk about involuntary medication. Each state has its own statute on involuntary medication, and each jail will have their own policies and procedures about how and when involuntary medication should be administered. The way we do it in my jail may not be the way your jail does it. In my jail, if a person meets the established threshold and warrants involuntary medication, my team will notify the sergeant's office that someone needs an involuntary injection. And a quick aside here, it is the medical or mental health department that should be deciding if someone does or does not meet the criteria for receiving an involuntary injection. I've run into situations where an officer said, "I don't feel comfortable doing this," or "I don't think this is actually a crisis," so they don't want to help give the injection. And listen, I get that giving someone medication against their will is unpleasant for everyone involved. But the alternative is to let them decompensate, harm themselves, or harm someone else. Also, if you prevent us from giving medication to a patient in an emergency, you've just taken all responsibility for whatever happens to that patient. Do you really want to be in court explaining that despite your lack of credentials, you interfered with an inmate's treatment? If you think something unethical happened, then by all means bring the situation to your supervisor, but I strongly recommend you let the experts make these decisions so that anything that goes wrong falls on them. Anyway, once the decision to give an involuntary medication has been made, a corrections supervisor should be contacted to determine if the special operations team is needed to help with the injection or if the officers in the section can handle it. Either way, once they figure that out, here is how I recommend that things go down. First, everything from here on out should be recorded with both handheld cameras and an officer body camera. You're walking into a situation that you know is dangerous. You're going to look incompetent if you didn't have the foresight to record it. Also, I know some people are afraid of the cameras because you think it might catch you doing something bad and you'll get in trouble. This is the wrong way to think about it. The camera is what protects you. If the inmate later tries to say that you did something inappropriate and file a lawsuit, you have everything on camera, so you're covered. Once your camera is ready to go, you want to have mental health go and try to talk the inmate into taking medication willingly. You don't have to get the whole verbal exchange. Just have it on camera so that a counselor is trying to talk the inmate into taking medication. If that fails, then record an officer trying to convince the inmate to take the medication willingly. If you have a court order for involuntary medication, you can bring the inmate a hard copy if you want to, but in my experience, even when inmates see that a judge ordered the medication, this has never convinced them to cooperate. Once all that fails, you've exhausted your verbal options, officers can then stack up and make entry to the cell. If you have them, you can use a shield or a defensive mattress when making entry to avoid strikes from the inmate. Once the inmate is secure, the medical staff can slip into the room, give the injection, and then everyone can exfiltrate and you can stop the recording. Once your team gets used to this, the entire process should take less than 5 minutes. If you have to do this more than once with the same inmate, or you think this is going to be an ongoing issue, you should consider petitioning the court to do a long-acting antipsychotic injection so that you can just do this once per month and you don't have to go in every day. That's much safer and more efficient for everyone if you can get a judge to agree to it. So that's involuntary medication. What if you have an inmate who is actively right now trying to harm himself or other people? This is a situation in which you might want to use clinical restraints. In my jail, we use a restraint chair, but this is not the only way to do restraints. 4-point restraints are another common method you'll see. There are some less frequently used restraint devices and techniques, but I've never used them, so I'm not really qualified to give you my opinion on them. In any case, the concept of clinical restraint is that you want to mechanically stop the inmate from doing something dangerous. You do this by taking control of their wrists and ankles so that they can't really move or grab anything. The thing about being restrained in either the restraint chair or in 4-point restraints is that it's unpleasant, but it's not necessarily uncomfortable. If you stay calm and you don't thrash around, you're either slightly reclined in a padded chair or you're laying face up on a mattress. Now, I have 2 kids, so I'm always tired. If you restrain me using either method, I would be asleep within a couple minutes. And it's not just me. I've seen a lot of inmates fall asleep in the restraint chair even without any medication. Basically, they're so ramped up when they get placed into the chair that after they've been in it for 30 minutes or so, their adrenaline wears off, their parasympathetic nervous system kicks in, and they get really tired. It's worth noting that even though this is usually how clinical restraints go, the use of clinical restraints is potentially dangerous if you don't know what you're doing. So make sure you have a good policy and procedure in place and your staff are trained to do it correctly. One thing I'll say about using clinical restraints is that you shouldn't be in a hurry to medicate everyone right when they go into restraints. You have to consider the patient and the context for the restraint use. Something I've seen several times are inmates who act out and cause chaos because they want you to put them in the restraint chair. Why? Because they've been in restraints at the psych hospital before and someone gave them an injection of sedatives to calm them down. Remember that a lot of people in jails have substance use disorders. Benzodiazepines are one of the most commonly abused drugs, and lorazepam, the drug most often used to calm psych patients, is a benzodiazepine. If you were to medicate someone like this, All you're doing is encouraging them to act out again so they can go back into the restraint chair. So if you end up using clinical restraints, you're going to once again want to make sure you record the entire thing on camera. You're also going to want to make sure you have someone constantly sitting with or near the inmate to keep watch on them. Someone needs to check vitals every so often, and you should be regularly checking to make sure the restraints are not cutting off the inmate's circulation. After the first 20 or 30 minutes, a counselor should check in regularly with the inmate to assess him and see if he's ready to be released from the restraint chair. In my experience, restraints don't usually need to go much longer than an hour, and anything over 2 hours is rare. If it's going to be longer than that, you'll need to plan out a timeline for when you're going to offer food and water to the inmate, allow them to move their limbs around to promote circulation, and do bathroom breaks. Usually, once mental health makes the decision to stop the restraint, you also want to put the inmate on suicide watch for ongoing monitoring. Okay, last one. Clinical seclusion. You will sometimes come across inmates who are not imminently harmful to themselves, but do pose a risk to other people. In this case, you can use a padded seclusion room. Not every jail has one, my jail doesn't have one, but I've worked in psychiatric hospitals that have them, so I know how they work. A seclusion room is basically just a room with nothing in it other than a light in the ceiling and maybe a drain in the floor. The walls, the door, and sometimes the floors are made of a unique material which is kind of a rough plastic, but behind the plastic are layers of foam padding. The rough exterior stops patients from digging into the wall with their fingernails, and the soft padding behind it prevents them from hurting themselves by punching or kicking the wall or running their head into it. There's no sink or toilet in the room because that would defeat the purpose, which is to give the patient a safe place to be for 20 minutes or so, maybe an hour, to calm down. You don't really want them in there for too long because, like I said, there's no bathroom. They're also eventually going to need to eat, and you don't want them throwing mustard and every other thing all over the walls. Okay, so this has been a long one, but that's the basics of crisis management in a jail. As always, if you have questions, just put them in the comments or send me an email. That's all the time we have for our session today. I'll see you next week.